Hello, I'm Norman Swan. Welcome to this program on polycystic ovary syndrome. PCOS affects reproductive, metabolic and mental health, and it's grossly under-recognised. Our program is based on the new evidence-based guideline on assessment and management of PCOS, which was auspiced by the Jean Hales Foundation for Women's Health and prepared by the National PCOS Alliance. The guideline addresses diagnosis, emotional well-being, lifestyle management and fertility issues. We'll have links to those and other resources on the Rural Health Education Foundation's website, rhaf.com.au. Now, our panellists are Jackie Boyle, who's an obstetrician and gynaecologist who practices in Melbourne and the Northern Territory. Welcome, Jackie.
Thank you, Norman.
Jackie's research interests are in reproductive health, health services, research translation and Aboriginal and Torres Strait Islander women's health. And Jackie was a contributor to the new PCOS guideline. Kate Marsh is an accredited practicing dietitian and a credentialed diabetes educator. She's founder of Northside Nutrition and Dietetics in Sydney and the PCOS Health and Nutrition Centre. Welcome, Kate.
Thanks, Norman.
Kate is the co-author of the Low GI Guide to Managing PCOS and has contributed dietary chapters to 2 textbooks on PCOS and obesity. Helena Teed is the Professor of Women's Health at Monash and Head of Diabetes at Southern Health. She's an endocrinologist at the Jean Hales Foundation and was Project Director of the new PCOS guideline. Welcome, Helena.
Thank you.
Working with the PCOS Alliance there. Nigel Septo is a Senior Lecturer in Exercise Physiology at Victoria University. Welcome, Nigel.
Thank you, Norman.
Nigel holds a research fellowship in the School of Public Health and Preventive Medicine at Monash, and his research interests are in the role of exercise and physical activity in managing insulin-resistant conditions and their associated complications. Welcome to you all. What is PCOS, Helena?
PCOS is a very common condition, Norman, which is often not diagnosed, and it is a combination of genetics and lifestyle that lead to a syndrome or a conglomeration, if you like, of characteristics which affect women's reproductive health, psychological health and also their metabolic health. And
never was a syndrome more poorly recognised.
Absolutely. So 70% of women who actually have the condition are not diagnosed. So that came from some very good recent research.
I mean, that's horrific.
That is, it's really high. And one of the reasons which we'll address shortly is primarily because often young girls, PCOS is not diagnosed when they're young, they're put on the oral contraceptive pill, and in fact they don't find out till many years later when they come off the pill.
And the prevalence in the community?
The prevalence actually at the moment is around 1 in 5 Australian women, and it's higher in women who are obese and higher in Indigenous women. Traditionally, on the old criteria, it was estimated to be about 5 to 8%, but we now know it's closer to around 18 to 20% in Australian women.
Why, Jackie, is it higher in Indigenous women? Do we know?
We don't know exactly, but we think that some of it is due to the fact that Aboriginal and Torres Strait Islander women tend to carry weight more centrally, so they have what we call more central obesity. So even at with a normal body mass index, they often have more central obesity than other women do. And other factors come into play, such as low birth weight, which predisposes them to having more insulin resistance, which I think we'll discuss later is also related to the development of polycystic ovary syndrome.
So do we know what causes it, Helena?
Yes, so the key causes of PCOS are both genetic, and the strong link there is a family history of diabetes, but also our lifestyle. Young women in Australia are actually putting on more weight than the rest of the population, and we know that women with PCOS are putting on even more weight. So it's that.
So does the putting on weight trigger the PCOS, or
yes,
what?
So in fact that's only become clear more recently that the key predictor of a young woman developing PCOS is actually her body weight and the rate of weight gain.
I think we've got a graph here showing that obesity effect as the obesity goes up. So let's have a look at that graph. But so what is it about obesity that does that?
Well, it's genetics and lifestyle together, and they actually cause the androgens and the insulin to go up, and with insulin resistance and high androgens, that's what causes the clinical features. And obesity makes both the high androgens and the insulin resistance worse. And you can see here, and this is Australian data from the Longitudinal Women's Health Study, that in women who are in the normal BMI range, the prevalence of PCOS is about 5%. Once you get to women who are over a BMI of 30, it's up to around 16 to 20%. And as we said before, in the Indigenous population, and indeed in Asian women and South Asian women, it's higher again.
And Talk us through the syndrome, because it is syndromic and therefore you're kind of diagnosing on the basis of an aggregate of symptoms.
So those hormonal imbalances we talked about, the high insulin, the high androgen levels, add together and you end up with three, if you like, distinct sets of clinical features. We can see there that the high androgens lead to hirsutism, acne, and often to scalp hair loss, which can be quite distressing for women. The androgens and insulin together affect the ovary. They're not cysts. The syndrome name really does need to be changed. They are actually follicles arrested in mid-development. But that leads to irregular cycles and infertility. And the primarily hyperinsulinemia actually leads to the metabolic, high diabetes risk, high lipids and increased cardiovascular risk. And all of that leads to the psychological features. And we can see here that there's the metabolic, reproductive and psychological groups of features in this syndrome.
So talk me through the psychological features. I mean, are they secondary to poor self-esteem, or are they part of the syndrome?
We don't know exactly yet, but what we do know from fairly extensive research, in fact in Australia, and most of the research has come out of Australia, that girls with PCOS are more likely to be anxious, they're more likely to be depressed, and those are more severe. They are more likely to have body image concerns and self-esteem issues, and also more prone to eating disorders because often there's a battle with their weight, which I'm sure Kate will allude to later.
So anorexia or bulimia or what?
Bulimia, not so much anorexia, more bulimia, binge eating and disordered eating, but it's often related to the fact that they have quite a significant challenge with their weight. So those psychological features appear to be because of the condition, and we do know, for example, if we treat the features of PCOS that bother the girls the most, if it's hirsutism or if it's their weight or if it's their fertility, if we treat those aspects, the psychological features often improve.
Right. Tell me about, you've done some work and research, Nigel, on weight-related insulin resistance. What sort of research have you done? What have you found?
The main research we've done is with Helena in a collaboration that we did over a few years, and we looked at the insulin resistance in overweight women with PCOS and overweight women without, and we've just completed our lean groups as well. And certainly in the PCOS groups there is a higher prevalence of insulin resistance. So no matter whether they are lean or overweight, PCOS women are more insulin resistant. And that's obviously part of the condition that Helena's related to.
And is it tractable to the same things that insulin resistance is affected, say if you've got metabolic syndrome, so if you're doing weight training, you know, the type of exercise you do, that can reverse the insulin resistance?
It certainly can. It probably doesn't reverse it to the same extent that it would in a woman without PCOS, and it wouldn't matter what exercise they're doing as long as they were active at this stage. We can certainly say that over a period of as little as sort of 2 weeks to as much as 12 weeks will definitely improve insulin resistance. But obviously when you get to those points, we encourage you to continue the exercise for the continued benefit of that in terms of the insulin resistance and the metabolic health that comes with exercise.
Kate, do you see a particular dietary preference in women with PCOS?
In terms of before they're diagnosed or
yes.
once? Yeah, I mean, a lot of them do have problems in terms of like reactive hypoglycemia, I think, and sugar sort of cravings. I mean, certainly that's anecdotally anyway. Report a lot. So a lot of them tend to have sort of what they think cravings for carbohydrate foods, and often related to low blood sugar levels, probably with the insulin resistance as well.
Talk me through the diagnosis, because there's what they call the Rotterdam criteria, and which is in the guideline.
So this is actually probably the most difficult area for clinicians and for women with PCOS is the diagnosis. So as you can see here, the original diagnosis within that was the NIH, or the National Institute of Health. It was relatively simple. It was anovulation or oligoanovulation, so irregular cycles, and features of excess androgens. So those features were either clinical with excess hair growth or biochemical on testing, and making sure that we exclude other causes. But in fact, in more recent times, the Rotterdam criteria actually added polycystic ovaries to the criterion. You need,
even though they're not cystic.
No, that's right, unfortunately. So you only need 2 of the 3. So you can actually now have a woman who has high androgens on blood testing and polycystic change on ultrasound with no symptoms at all, and they have the more mild features of the condition. But what we now know is that the NIH women, the original diagnostic criteria, are the most severe, whereas the Rotterdam criteria have opened it up more broadly, but those women definitely still have increased metabolic risk.
And this is how we get to 1 in 5 of the population.
Yes, but they still very much have those metabolic features, even though their reproductive features are more mild, so we do need to capture them.
Do we know what the track is from, say, a young girl of 9 or 10 through to a young woman of 25, 30?
Yeah, we do, and in fact that's been really interesting data that's come out recently. So for example, daughters of women with PCOS actually are more insulin resistant in their late childhood, more prone to gaining weight, more likely to have early menarche.
So the genes are already operating
genes are
independent of lifestyle?
Absolutely, and then we know that once they hit menarche, they become more hyperandrogenic, and that those features together, the androgens and the insulin, then lead to the clinical syndrome that
This is when the acne, the
hirsutism, irregular cycles, etc. So they track in that way, and as they get older, the metabolic features become more prominent, whereas when they're younger, the reproductive features are often worse or more severe. But the other thing that happens now is, because we are all, as women in Australia, gaining weight as we get older, the clinical features are often exacerbated as we're getting older because the weight gain is so marked. So the history is often that of insulin resistance and hyperandrogenism, and then all the metabolic features and reproductive features come out after that.
Susanna from John Hunter Hospital asks, do you have any useful information for breastfeeding women with PCOS? Jackie?
I think...
Why did you look to Helena?
Oh, no,
was it phone a friend, or?
We were discussing
this earlier. Discussing this earlier. We were talking about the fact that there's not really any evidence around breastfeeding with women with polycystic ovary syndrome, but that anecdotally we've both heard that women do seem to report that they have more trouble initiating and maintaining breastfeeding. But no, so we don't actually have any magic answers.
Have you ever tried exercise with breastfeeding women with PCOS? I mean, if the symptoms go away, the breastfeeding gets easier, or?
That's a very interesting question. I haven't gone down that line of research, so I couldn't give you a definitive answer.
You need a fairly thick sports bra, I suspect.
Although, Norman, I'd have to say that we'd still very much encourage women with PCOS to breastfeed, as not only for the nutritional benefit of the infant, but also to shed that extra weight that often comes on in pregnancy. Because the weight gain is such an issue, that's a really important physiological mechanism.
Get right into
Absolutely.
It. Susan Downs of Derby Hospital has diagnosed a large number of women with PCOS and wants to know when's the best time to start metformin.
Good question. We were also discussing this earlier. And in fact, this will come out over the course of tonight. But really, the first-line treatment for women with this condition, whether they're in the healthy weight range, and again, Kate will talk about this, or whether they're overweight, is lifestyle. Lifestyle in other populations and also in PCOS is actually more effective than metformin in terms of its impact. So it's very important that we don't put metformin there as a crutch or as an excuse for lifestyle. For normal weight women, the intention of lifestyle and exercise is to reduce the insulin resistance and prevent weight gain and maintain health. For those who are overweight, it's to get at least that 5 to 10% improvement in weight, which will give you significant benefits. Metformin depends on the indication.
Reduction in weight, 5%?
Yes, so 5 to 10% reduction in weight gives you a dramatic impact in terms of health. And that's an important message, and I'm sure Kate will talk to that shortly.
And I think your practice is to really go for intensive lifestyle change.
Yeah, combine behavioural exercise and dietary caloric restriction. But the really important message for the women is you don't need to get down to a normal BMI necessarily. You'll get a big benefit just by dropping that 5 to 10%. But to get back to your question about metformin, it depends on the indication. So metformin will give you menstrual regulation if lifestyle is not effective. It will also improve fertility, and again, Jackie will talk about that later on.
And it'll help with weight loss, won't it?
No. Now, this is very important because it's probably one of the main reasons people use it, so it's a good point.
So this is a myth?
Well, what we know is that metformin in some women can cause a bit of an appetite suppressant effect. So there are a small number who may lose weight, but overall it doesn't cause weight loss. However, it does seem to prevent or reduce weight gain. So that weight gain we were talking about of 2 to 3 kilos a year, very important over a decade. And over 2 decades, we're talking 10, 20, 30 kilograms. Metformin seems to help prevent that weight gain. So that is a useful initiative, but we definitely wouldn't mandate that metformin's the right way to go about weight management. It really is about lifestyle.
A GP from Kuma asks, in a newly diagnosed 18-year-old girl with PCOS, normal BMI, commenced on COC. What's COC?
Oral contraceptive pill.
Oral contraceptive pill, right. What else do I need to do in terms of further surveillance or management?
Oh, well, I think that assuming that she had all her blood tests done before she started the pill, That would be good. The other important things to know...
So, sorry, we're going to come to this later, but let's do it now.
Okay.
So you want to get baseline androgen levels done before you start the pill?
You want to confirm your diagnosis and exclude any other cause of the symptoms, and the oral contraceptive pill will change those blood levels, so you really need to do it before they go on the pill, or if someone comes to you at some point and they've been on the pill for a while, they need to be off it for 3 months before you do the blood tests. And the tests that we're talking about, total testosterone, a sex hormone binding globulin, and then that will enable you to get a measure of either some form of free testosterone or free androgen, so a free androgen index, a calculated free testosterone, or a bioavailable testosterone.
Can you get that done in your local pathologist in a country town?
Yes, you can. Yep.
Right. A midwife asks, just while we're on about contraception, what would be the best contraception option for obese women with PCOS and acne?
Very good question. The challenge with obese
a very good audience.
Yes. The challenge with obese women generally is there's an increased risk of complications of the contraceptive pill, including thrombosis. And there's also not a lot of efficacy data with contraception in women who have a significantly elevated BMI. But the literature in PCOS would suggest we're trying to get the oral contraceptive effect through the liver to increase sex hormone binding globulin, and that's quite important because it then soaks up all that free testosterone and has that good efficacy that we're looking for in terms of hyperandrogenic effect. So we do tend to go for oral contraceptives, but the challenge is that there is some suggestive evidence that there's an increase in insulin resistance with contraception. That remains controversial, but for that reason we tend to go for lower dose contraceptives, so the 20 microgram if women can tolerate it. And it's still worthwhile considering things like Mirena. You've got a progestin which will balance out the continuing estrogen load these women have in the setting of anovulation, but that doesn't give you that first pass effect. There is some evidence with Implanon that it also may increase insulin resistance. So it's a matter of looking at the metabolic and the reproductive needs of each individual woman and working through that with the woman. Generally we use oral contraceptives though.
And sorry, could I just go, just that question about the 18-year-old, I think the other main point is just to let her know about what can happen when she gets older, when she comes off the oral contraceptive pill, that her periods, if they've been irregular, will quite likely go back to being that, because a lot of women don't understand that that will happen, and that therefore...
Because that's their baseline state.
Yeah, and that therefore that may then affect her fertility. So she needs to be aware of that later on, and also just that trying to prevent weight gain, making sure that she understands the importance of that, and having ongoing surveillance, not just giving her a diagnosis and the pill.
What's the commonest pattern you see, Helena, of somebody who's been missed for a while? Because I think it takes up to 5 years. I think we've got a slide on this of the journey to diagnosis. Let's just have a look at that slide. And why it's missed.
Yes, so this was actually, again, Australian research, and around 90% of girls with PCOS had to see more than one health professional, several. They take quite a long time to be diagnosed. We know that 70% are actually undiagnosed, and many of them are not very satisfied with the way they were diagnosed. And one of the main reasons it's missed is, and Jackie and yourself will talk shortly about the adolescent time being difficult, but often girls are simply told your cycles are irregular when you're an adolescent, so we'll just pop you on the pill, but not investigated for PCOS. The implications of that, Norman, though, are if they're not caught, just as Jackie said, they may have that increased weight gain for all of those years in their 20s and not think about fertility or pregnancy planning. And that's really vital, because the key factors that predict your fertility in future are in fact your weight, and we know a BMI over 30 has quite a negative impact on fertility, and also your age. And again, ideally we're talking about women having their pregnancies before 35, because that does impact. So if we end up with PCOS and weight and age, it's very hard to overcome. But if women are aware of those things, that we can work on lifestyle during that early time because they've got their diagnosis, that's important. And the other area is their metabolic risk. They are at much higher risk of diabetes, they're at much higher risk of metabolic syndrome, and we need to screen for those during even those young reproductive years. And we miss that opportunity to preserve fertility and preserve metabolic health and deal with the psychological issues if they haven't been diagnosed.
The guideline, it's a big guideline, it takes a long time to think, but there's 5 algorithms that really people should focus on.
Yes. So the main evidence table is about 1,000 pages, the guideline's about 190. the Medical Journal of Australia is about 40 pages, but this is where you really come
This is
to
where
it.
the money is.
So there are 5 algorithms available on the website or in the guideline, and essentially they cover diagnostic issues and metabolic risk assessment, which tells you how often and what to screen for, assessment of emotional well-being, which we'll come back to, lifestyle management, management of infertility, and which interventions to use in terms of infertility. So all the gold is just there.
A question for you, Kate, from a consumer. In Queensland, I think it is. I've put on a rapid amount of weight, 27 kilos in just over 2 years. I've tried everything to lose it. Any suggestions? Thank you, with a smile, is the question there.
So, I mean, it's certainly something that I do see in practice, and I guess it's a matter of...
It's a lot of weight.
It's hard to, definitely, and it's, it's those factors we've talked about in terms of the insulin resistance, and, once you do put on some weight, then it can make the insulin resistance worse, and it becomes a bit of a spiral.
So what do you do
It's
as a
not
dietitian
uncommon.
in that situation?
Well, I guess it's hard to obviously give general advice, but I guess be looking at what the person is doing now. So I look at it from, from a dietary point of view and what sort of things that we might be able to change. Certainly looking at exercise, which Nigel's talking more about, and looking at other factors like sleep and stress and things that can also impact as well, because all of those
And what's the
come
influence
together.
of the low GI diet? I noticed you've written a book on that.
Yeah, so what we found certainly from doing the guidelines is that there's not a lot of evidence in terms of specific dietary composition in terms of managing PCOS. We know that cutting down calories and eating a healthy diet is actually really going to help. But we certainly know from other conditions in terms of weight management, in terms of diabetes prevention, that a low GI diet is beneficial, and because it's the same underlying problem with PCOS, and there's certainly some suggestion that may be helpful. It's an area that we need some more research on.
And the one thing that you don't do in diagnosis is ultrasound, is that right? Even though it's one of the diagnostic criteria, particularly in young girls.
Yeah, only in young girls, in adolescents, because up to 69% of adolescents can have ovaries that have that polycystic ovary appearance on ultrasound. So it's not a diagnostic criteria for adolescents. It's different once you're past that stage. And the other issue, obviously, is that you don't want to be doing transvaginal scans before women become sexually active.
And I think we've got a picture of a polycystic ovary on ultrasound, which we might show you in a moment after I've asked. There we are. There's the picture on ultrasound, a very classic picture. So which are not cysts, they're
Follicles.
interrupted follicles. Another question from Mount Gambier is, I'm 36 years old and we're 123 kilos. I'm on my 3rd IVF cycle. Can the panel give me any advice, please? Jackie.
Look, it's very difficult to know individual circumstances like that. However, 123 kilos, obviously trying to address some of those lifestyle issues, it would definitely
So that's going to be
help.
on average height, BMI of 35 or higher.
Yeah, so I think that really those lifestyle issues would be the thing to address, because that can help the success of things like IVF.
And again, we're talking about fairly small changes. Even a 6 to 7 kilogram weight loss for someone at that weight would make a very positive impact on the insulin resistance and the efficacy of other therapies like IVF.
So talk me through what you would do with a woman like this and exercise, and what the pattern would be, how you would get them going, and how intensive it really has to be. Because my understanding from the work that Jean Hales is, this is not trivial exercise you've got to do. You've got to really work at it.
Helene is correct. We only need a small change, and obviously personal circumstances of each of the circumstances make it a bit more challenging. But certainly in terms of someone who is looking to do IVF, there is definite benefit to undertaking exercise, and that can be as little as just going for a walk every day, following the recommended guidelines. The benefits of that are unbelievably large in terms of insulin resistance, which does have a major impact on fertility. So if you can reduce that insulin resistance, obviously there's some issues there that we haven't really discussed about what's keeping people from exercising. So there's barriers and motivators to exercise. So someone who is maybe 123 kilos or is going to struggle to potentially do exercise, but it doesn't mean they can't do exercise. And in essence, if people in that situation are able to, they can certainly engage in accredited exercise physiologists, which are available throughout the country. We just need to track them down on the website. There's a website for the Exercise Science Australia, and they list accredited physiologists, which are actually Medicare-based exercise physiologists who can help them on the path.
Including in rural areas?
Including rural areas, yes. They may be a bit limited in the rural areas, but certainly there are, in the major rural centres, will be some exercise physiologists available to people for that. And they would certainly help with behavioural motivators and barriers to get them going.
Jan, a psychologist, asks, what was your response to lap banding as an adjunct for treatment of PCOS? Helena?
So we did deal with this in the guideline, and it was actually one of the more controversial areas. I think lap banding in general is very controversial, especially as a public health clinician. I would very much love to say we could fix everyone's problem with lifestyle. But the sheer reality is people with very severe obesity that's very established, there is actually, on a population level, generally no other alternative than something as effective as a lap band. It has around 80% effectiveness. It cures most people with diabetes. There are definite benefits. There are side effects and there are long-term concerns and there are significant compromises. But in
Such
PCOS,
as liquidising your chips.
Well, yes, there are ways around it, but 80% of people do have a good benefit from it. So I'm definitely not advocating it, but there are times where it's appropriate. And one of the times we dealt with it specifically in the guideline is fertility. So the case that you brought up before, the risks for that for women who are quite overweight is in terms of actually getting pregnant is a risk, but once you get pregnant, the risks of during the pregnancy are quite high, and there may also be some risks for the baby's health long term. So in the setting of looking at fertility, if women, the guideline recommended that if women had a BMI over 35, especially if they were getting older, so we had less time for lifestyle intervention, then bariatric surgery was one of the options for them to consider. They obviously need to go through all of that, and it needs to be after intensive lifestyle intervention, but it may be an option.
We have a question for you, Nigel, from Western Australia, from Mark, who says, I'm a personal trainer and was wondering if there are any exercises that are particularly good and any that should not be done.
That's going to basically depend on the client that you're dealing with, so injuries, things that they struggle to do. The advice would be to find exercise type training programs that the person will enjoy. That could be encouraging them from taking up a team sport to individual training. So there's plenty of ways of getting people active, but at this stage I wouldn't be able to say exactly what is the best kind of exercise. What I can say is that all exercise, from resistance training to cardio classes, are all going to be beneficial to someone with PCOS.
And your views at shouting and screaming at the client?
Depends if it works or not. If it's a good motivator, go for it, but if not, maybe not.
Let's go to our next case study. Jenny is an Indigenous woman of 28. She's been diagnosed with PCOS for 6 years. She weighs 84 kilos, BMI 32. She comes to our local AMS with depression, complaining of fatigue. She's smoking 20 a day. She's not on any medication. How would you approach Jenny here, Jackie?
Well, I think that there's a few things that we need to know about Jenny. I think, so she's had polycystic ovary syndrome for 6 years now, so it would be interesting to know whether she has had any lifestyle advice or help.
So let's assume she hasn't.
Well, she has. It hasn't worked very well.
Yes.
She has a BMI of 32 now. And even if she hadn't worked, then that indicates that we really need to look at factors that are influencing her health behaviour, and I think that's something that often gets overlooked as well. Some of them are more larger social factors, but some of them may be within her family or individual factors that you can help her address and give some practical suggestions. The other thing with Jenny is, we would want to know whether she has had children, whether she plans to have children. That might influence our management. And obviously the big thing for Jenny is going to be around her cardiometabolic risk. The risk of diabetes and heart disease is increased in polycystic ovary syndrome, and it's particularly increased in Aboriginal and Torres Strait Islander women. So with that background and smoking and a BMI of 32, they're all additive effects, so we would need to look at screening her for diabetes, looking at her lipids, her blood pressure, and monitoring her BMI and waist circumference. We'd probably want to know a bit more about her family history as well, and indeed look at whether any other family members should potentially be tested for diabetes or for PCOS.
And multifaceted lifestyle intervention in someone like Jenny?
In terms of management, yes. I think that in some settings with some Aboriginal medical services, particularly some of the more urban ones, they do have a lot of allied health staff. It does become more difficult in some of the rural and remote areas. Some of those places have Aboriginal health workers who are working with chronic disease or with nutrition and more wellbeing programs.
So you've got to work with the resources you have.
Yeah, but I think it's really important for services to look at how they can try and develop a system that will help Jenny, because a consultation with a doctor or a nurse as a one-off isn't really going to be to help her sustain lifestyle changes.
Kate, the recurrent message I'm getting here is this is not for the lonesome cowboy or cowgirl in their general practice. This is something you've got to actually bring other people in to help.
Yeah, definitely. I mean, we know it is, there's a lot of issues going on, and these women do need a lot of help in terms of, putting lifestyle practice and obviously managing the medical side of things. So it's about having everyone working together, and I guess being able to provide as much help as they can and get the advice, because there's a lot of conflicting information out there, and I think a lot of these women are confused about what to do, and just to be able to get that right advice and have the right sort of help and support is really good.
What does the guideline say about multidisciplinary care, particularly in the difficult circumstances where GPs in country towns are often just pulling whatever resources they can together, relying on the practice nurse to do the coordination? It's not an easy task, and this is yet another chronic disease they're being asked to look after.
Look, it is. I think if I can make a point first, that the psychological state, which we do need to focus on, is one of the important things in these women, is actually recognising the psychological features and starting to deal with those, like potentially in Jenny. Because if we can do those, the women are much more likely, which can be done with a GP, and there's a very simple screening tool in the guideline with specific questions. You can ask 8 simple questions and get a feel for the key psychological factors in this condition. That's a really important starting point. When we come to working through with the GP, even things like regularly weighing the women and actually setting goals and talking about prevention of weight gain, we know works. The multidisciplinary team is really important, but the multidisciplinary team might vary. There may not be an exercise physiologist, but there may be a really good community health program. Sometimes in the rural areas, the resources around the GPs are actually sometimes better and focused in one area rather than having to visit 9 or 10 different places. So I think the practitioners and the women who are in those areas know what is best and what is available. Sometimes having that rapport with an individual Indigenous health worker or a community health nurse or a practice nurse can be what you really need to work through. But whatever you've got, the more the better, and as long as we keep the women at the centre of their management.
So what are you going to do about Jenny's fatigue and depression?
Yeah, I think first of all we need to obviously look into other causes and make sure there's nothing else going on. But given that these women do have a higher rate of depression, and given that we know that the medical features, issues about fertility, body image, often the struggle with weight, hirsutism, the central obesity pattern, those sorts of factors have significant psychological input. So the first thing would be, obviously we need to assess the depression and treat and manage accordingly, but we also need to think about the factors in PCOS that we can modulate that will actually improve outcome. And we also need to be careful about the way we sell the lifestyle message. These women know lifestyle is important, and they often feel very demoralised and know
hard to get going.
Absolutely. And so that's why that psychological issue is so important. That's also why prevention of weight gain has to be the most important message, and the small weight loss is very important.
So does cognitive behavioural therapy help? Do SSRIs help?
There's no evidence that the depression in PCOS is a different form of depression. Admittedly, not a lot of research, but there's not evidence that it's a different form of depression. We need to treat it differently. So the guidelines really focused on raising awareness of practitioners and women that this was a problem, in getting it recognised and then treating it accordingly. So the treatment really only varies in that we have to help women with the clinical features of PCOS. So we need to treat the hirsutism or treat what bothers them most. And to come back to the other point, with Jenny or with anyone with PCOS, we need to work out what's most important for them. The hirsutism may really bother them, or they may not care. It may be that they're really worried about scalp loss, or they're actually really worried about getting diabetes like their dad. So it matters most importantly to establish the psychological baseline, screen and address the issues there, then to find out what's most important for them and address it, and then really to support them with lifestyle change, with those realistic messages about small change, and any change is good.
How often, Jackie, should Jenny be followed up, and with what sort of investigation. So Helena mentioned regular weighing and so on, and that would obviously, if you had a dietitian, the dietitian could be doing that with the dietetics advice. But what, in general, should be the follow-up pattern for someone like Jenny?
Well, generally they need screening for diabetes, and the
How often?
The guidelines recommend an oral glucose tolerance test once every 2 years unless they have other risk factors. So that was partly what I was alluding to before as well. So Jenny has increased weight, and also if there was a family history, then you would do it every year then. You need to check their lipids. And again, that's every 2 years, but if there's other risk factors, you would do that more frequently. You would do that annually, and they need to have blood pressure checks regularly. And I think there was certainly some debate around using an oral glucose tolerance test when the guidelines were being developed, because it is quite onerous, both for the woman and for the health service. But I think
particularly in a remote community.
That's right. But I think Helena was involved more in those discussions.
Yeah, so the
Blood on the floor with that one.
Yes, no, there absolutely was. Look, the oral glucose tolerance test at the moment is the most ideal way to investigate these women, largely because we're hoping to get them before they get diabetes. So, Norman, the evidence now is that, very small lifestyle change can actually prevent diabetes. So the large trials overseas, the diabetes prevention trial, etc., showed that with a 3 to 4 kilogram difference in weight, we can reduce the prevalence or the onset of diabetes by up to 60%. So what we're hoping to do is catch these women who we know have between a 4 and 8-fold increased risk of diabetes, and we know it occurs at a much younger age. We would like to catch them when they have pre-diabetes and use that as a motivator and focus on the metabolic aspect and get that lifestyle change. Without an oral glucose tolerance test, we simply don't have the accuracy.
So fasting blood sugar doesn't help you?
No, it doesn't. And in fact, it misses 80% in PCOS. There's something, we don't know whether there's something specifically metabolically about these women, but it misses 70 to 80% of young women with pre-diabetes with this condition will be missed by fasting blood glucose. And even an HbA1c, which is now touted as potentially the new diagnostic measure, is not particularly good at picking the pre-diabetes in these women. So really we did come down to an oral glucose tolerance test. In practice, you can just ask for the baseline and the 2 hour. You can actually skip the 1 hour extra blood test. We don't really use it in clinical practice, and it's just an extra blood test for the women. But it is actually important to check.
And is PCOS a life-shortening disease?
Again, a very good question, Norman. There is definite evidence that there's a significant increase in diabetes, and we know that diabetes has a marked impact in terms of increasing risk of heart attack and stroke. We also know that it's associated with obesity and increased weight, which again is life-shortening. In fact, now in Australia, obesity is the primary risk factor for chronic disease. It's taken over from all of the other traditional risk factors. So we know that if you've got PCOS, you're more likely to be overweight. If you've got PCOS, you're much more likely to get diabetes. So from those perspectives, yes. We know they've got much higher risk of cardiovascular risk factors. We don't have any good long-term data about heart outcomes. The data is suggestive that there's a higher risk of stroke and heart disease, but we simply don't have good studies.
You just assume that from a thing. In fact, we had a question from Marissa Pillar in North Queensland asking about whether or not there's an overlap between how you manage pre-diabetes and how you look after somebody here. And in fact, what you're saying is you do the same thing.
Absolutely.
And the question here is, does a history of eating disorder and low BMI affect the development of PCOS, almost the flip side of obesity? In other words, is there less PCOS in people with anorexia nervosa?
Well, interestingly, there's often a hormonal environment in anorexia where there's often quite low androgens. There is almost certainly a hormonal contribution or consequence, if you like, of anorexia. We don't really know how that links to PCOS, and that's, to be honest, I'm fairly au fait with most of the literature, and at the moment we don't know. But it is true that there's increased risk of eating disorder, but primarily binge eating and bulimia in girls with PCOS, and often related to the weight challenges that they experience.
Adele from Alice Springs Pharmacy asks, do you recommend the use of anti-androgens such as spironolactone?
In some situations. So the problem with spironolactone is often it's used for
women.
It
increases the hair loss for a start.
Well, not so much, but it's more that we're cognizant of the fact that these are young women, and any medical therapy for a long period of time is an imposition, but we don't have good data about long-term use of anti-androgens. So for hirsutism, we're actually going first-line cosmetic therapy, especially for facial hirsutism in women.
So
who don't-
lasering?
Yeah, laser. Especially if they've got pale skin and dark hair, it works very effectively. And there are a range of cosmetic
Bit
treatments.
painful.
Well, yeah, electrolysis particularly, but it is often very effective, and most of the girls who've had laser find it really beneficial if they can afford it. It's mainly the painful on the hip pocket that's the real issue, and access to that in rural and remote areas. But also the next line then is the pill, which can often be quite effective, but please leave it to about 6 to 12 months because you won't see the optimum efficacy till that time. With anti-androgens, we often add those primarily for women who've got scalp alopecia. And that can be really quite distressing. It's often
it's male
genetic.
pattern baldness.
Yeah, and young women who are getting male pattern baldness are often very distressed by that. So we'll often use it in that setting. One of the issues about the anti-androgens is that you really need contraception with them. If you use aldactone alone, the bleeding patterns are often disturbed. And if a woman gets pregnant on an anti-androgen, the risk of abnormalities in the male fetus is significant. So we need contraception as well as the anti-androgen. So yes, we use it, but I think less and less these days, and primarily for the more severe features of hyperandrogenism. Would you agree, Jackie?
Yes, yes.
Interesting question here for you, Jackie, from Kirsten in Queensland, from ACRIM, the College of Rural and Remote Medicine. What's the effect of PCOS on the menopause?
Well, the cycles actually tend to resume a bit more towards normal as women become older. So going into menopause, it doesn't actually tend to change menopause so much.
So does that mean a late surgence in fertility?
Well, there can be. You certainly can have sporadic ovulation as your cycles are becoming a bit more normalised. I think the other women who are carrying more adipose tissue are making more oestrogen, so they sometimes tend to have less things such as hot flushes. But I think that the main thing that we would probably want to say about women as they're approaching menopause is really monitoring those metabolic effects, because that's when they're going to be most at risk, is that they're heading into midlife and later life.
A question from Jessica, a pharmacy student in South Australia. What are the risks if PCOS remains undiagnosed or untreated?
The biggest risk would be that weight gain we talked about before, that if women are not aware of the fact that they are more prone to weight gain and those metabolic risks, they won't necessarily, so the fertility side, they won't necessarily plan their families with optimum weight and at optimum age. They also may not be screened for the metabolic risk. They may go straight through to diabetes and not be diagnosed with pre-diabetes, and we've lost our chance. And also the psychological impact of their condition won't necessarily be recognised. So the key risks are just not addressing the features of the clinical syndrome.
A question here from Heather, a GP in Queensland. I occasionally see young women over 20 with a normal BMI, oligomenorrhea, polycystic ovaries, and no signs of hyperandrogenisation or hyperandrogenism. Do they have PCOS? And I assume by oligomenorrhea we're talking about assuming, Heather, you're talking about oligo-ovulation. So in other words, there are fewer periods rather than necessarily a small bleed during menstruation.
Yep, so they do, by definition, have PCOS, but they have the more mild type we talked about before. So they've got the oligo and ovulation and the PCO and ultrasounds. They've got two features. We've done quite a bit of research in this area, and in fact, most of the research comes out of Australia showing that even though those women have the more mild reproductive type and don't have hyperandrogenism, they still have metabolic abnormalities, and they in fact still have psychological impacts. So it appears to be more mild. It's the more mild reproductive features, but they still do need diagnosis. It's almost, we actually proposed it was almost like a pre-PCOS. In other words, they have features but not as bad as those who have hyperandrogenism.
Susan's 29. She's married with no children, lives in Cloncurry. She was diagnosed with PCOS 8 years ago and has been on metformin for the last 6 months. She and her husband want to have kids, but they've been trying unsuccessfully for the last 18 months, and she's been referred to the specialist, that's you, Jackie, to discuss her fertility, and is wondering if she should be taking fertility drugs to increase her ovulation. Her BMI is 30.
So Susan has a BMI of 30, so she's at that borderline that we were discussing before, where metformin may be effective. So it was quite reasonable for her to try that. We don't know whether she's tried lifestyle management yet, and as we were saying before, even a small loss of weight of 5 to 10%, so we're not talking large amounts, may well be beneficial. So given that she is 29, ideally that would be the next best thing to do. And then assuming that, if we assume that she does that and then she's still not successful, then it would be time to move on to further methods.
Such as clomiphene?
Well, yeah, the next line would be either adding clomiphene or the other second line treatment that the guidelines suggest might be appropriate could be laparoscopic ovarian surgery, where holes are drilled into the ovaries and it changes the hyperandrogenism. And
Does it?
Yeah, and then you get...
This sounds like a well thought out, delicate, sophisticated gynecological procedure. You drill holes in the ovary.
very, very delicate.
Oh yeah, I'm sure. Yeah, yeah.
And you do get
So somebody just thought, well, why don't I drill a few holes in the ovary? It must
Well,
help.
actually, it started off more brutally than that. It used to be wedge resection, where they would literally take a wedge out of the ovary, and
Right.
it wasn't done through a laparoscope, so that was much more dramatic. I think you need to weigh...
Has there been a randomised trial of this?
Oh, yeah,
There has, right.
And I think that what you need to also take into account for Susan is where she lives, in that if we added clomiphene in now, which would probably be what we would probably consider in the city, the problem is that there's a 5 to 7% chance of multiple pregnancy, usually twins. There's a less than 1% chance of ovarian hyperstimulation. So the risks are low, but generally now we would recommend that you have monitoring with that, and not everyone's able to prescribe clomiphene. So if, for example...
Well, you've got to be accredited to prescribe it?
It varies by state to state, yeah.
Right.
But if, for example...
So if you're a rural GP obstetrician, you would be able to do it, presumably? or not?
No, quite possibly not in
Not,
many
right.
places, yeah. So I think that, you know, if, for example, and particularly if there was another reason, if you were concerned perhaps about whether she had endometriosis, or if there was any concern potentially about whether her tubes were patent, that would make it very reasonable to do a laparoscope and at the same time do ovarian drilling.
Yeah, the endocrinologists are a little bit more uncomfortable with this, is what I have to say. And this was, again, a great topic for debate at the guidelines.
But the benefit, it has certainly been shown that over a year it may well be as work as well as the other methods, and you don't have to worry about monitoring her for those risks, particularly for multiple pregnancy.
So when it's going to be... Do you know the number needed to treat? I mean, for ovarian drilling, how many women have to be drilled for one pregnancy? Do we know that?
It's not much different to clomiphene. I mean,
No, it's
I hate to admit it.
Even though
because
you're sceptical?
Yeah, no, I'm not sceptical. I just think it's quite barbaric. But that's because I'm not a gynaecologist. One of the concerns about laparoscopic ovarian drilling is potentially the long-term risks. There actually isn't any long-term studies, and the problem, as Jackie said, is used to be quite barbaric, and potentially there are problems with adhesions. I believe these days that's far less of a problem. But surprisingly, it has efficacy and it changes the hormonal environment. Not first line, but it's second line.
Once you've had your ovaries drilled, is that like a once and forever thing where you're now fertile, or what?
No. So
It's just like it lasts a year and then they close over.
well, it's unclear as to how long the benefit lasts. For some women, it can last for quite a long time. But certainly, if you weren't pregnant, if you were ovulating and weren't pregnant within a year of having that done, then you would certainly move on.
Right. So let's go back to Susan at 32. She's had her first kid. Let's assume she hasn't been ovarianly affected. At 35, she comes back to see her GP. She's concerned about weight gain since the birth of her child. Her BMI is now 36, and she wants to have another child before it's too late. Jackie.
Well, I would really have liked her to come to see me before now.
Yes.
Now that she's 35 and has a BMI of 36. So the recommendations are that if your BMI is over 35, because of the decreased chance of success, even with treatments such as clomiphene and IVF, it's usually recommended that lifestyle is the first-line treatment. The difficulty is going to be with her that she is now 35, so you would really encourage her to...
So everything just gets harder.
It does, because her fertility is decreasing because of her age as well. So there's no real right answer, I don't think, for this. I probably would still be inclined to get her to try 6 months of lifestyle some quite intensive lifestyle treatment if that was possible, to see if she could even lose a small amount of weight in that next 6 months.
And is there any role for GIFT or assisted reproduction here at all?
Well, yeah, I mean, for any of the... I'm assuming that she's not ovulating, and so yes, then the other thing that you would try as the next first line would be clomiphene. But going back to those what we discussed before, then there arises, do you either do that unmonitored,
yes,
if someone can prescribe it, which is what everyone used to do, or do you send her somewhere to have treatment where she can be monitored? So I think ideally the best thing initially would be if she could have 6 months, and even if she still doesn't ovulate regularly after that 6 months, she's then going to have more benefit from any treatment that you then do.
Helena?
Just to make the very important point there that most of these women don't need IVF, and that's actually a really important point about the guideline, that in fact many of these women will respond to lifestyle or the first line treatment with clomiphene, or either clomiphene or metformin if they've got a BMI under 30, or indeed potentially even gonadotropins. But most of these women, if they don't have another infertility factor, like Jackie mentioned, for example, tubal patency or whatever, or male factor of fertility, don't need to go on to IVF. And yet that's one of the concerns that perhaps many of the women with PCOS are actually going through to IVF without necessarily needing to. We know lifestyle is effective, very cost effective with many other benefits, and yet at the moment there is concerns about the fact that there are perhaps a little bit, a few more than are needed who are actually going through to very expensive IVF therapy when it may not be appropriate.
Now, I've got a question here for you, Kate. I'm 27, about average weight. This is again another one. I suspect this is a clinician who's also a consumer. Average weight, been trying to conceive for 15 months, taking metformin and clomiphene. Should I be on a diabetic diet? Would that help?
Yeah, so as we've talked about, I mean, lifestyle is still really important, and I guess it is sort of first line, I mean, even with those other treatments.
But a diabetic diet's not going to help you lose weight, is it? That's just about carbohydrate swaps and stuff like that, isn't it?
Well, it's about managing the insulin resistance. I mean, certainly we're looking at caloric intake as well and trying to get some weight loss, because we do know, as we've talked about before, I mean, even a small amount of weight loss can make a big difference in terms of fertility and in terms of, reducing the risk of gestational diabetes as well.
Are some people using aromatase inhibitors?
Good question.
Yeah, that's a good question. I think it is being used overseas. It's the label, the use is
Aren't they pretty toxic?
Is off-label. We don't really know the long-term effects in pregnancy. So generally in Australia it's not being used, and it wasn't recommended really to be used by the guidelines, and certainly if it is used, it's only used in women who are clomiphene resistant or clomiphene failures.
So they'd be expensive, wouldn't they, as
Yeah,
well?
well, we've actually, in the guideline, we've actually recommended not using it for all the reasons that you talk about. But this woman has had well over 12 months of therapy, you said, with clomiphene and metformin. Yeah, so that's really at the point where you'd start to look for the next option. And I agree with Kate, ideal lifestyle, but if she's got normal weight, she's been on metformin plus clomiphene, it really would be a time to go and look for the next step. And in her case, that might be the exception around IVF therapy.
And you're certainly not meant to use Clomid for more than 12 months.
Question from Western Australia. Any suggestions or recommended treatments for scalp hair loss? You alluded to some before, which is anti-androgen, but you've got to be careful.
Yes, a couple of things. We need to make sure that the women are not iron deficient or zinc deficient and have got, are well nourished, because diet can have quite a big impact on hair. The other thing too is that it's not uncommon in young women to actually have a stressful event in their life and lose hair at that time and then potentially regain. So we need to make sure that it is actually a condition that we can't treat in other ways through diet and lifestyle. But yes, then the pill is one option, and also plus or minus the anti-androgen we discussed before.
Another question from Queensland, Nigel. What are specifically the exercise recommendations in the guidelines?
The specific recommendations at the moment are 150 minutes of exercise a week, which is about 30 minutes 5 days a week.
So that's nothing more than the standard NHMRC guidelines?
Yeah, but there's also there's a requirement for 90 minutes to be vigorous exercise, so greater than just your going for a walk. So you need to look at increasing the intensity of the exercise. And in saying that, there's some new research coming out of both Australia and overseas that's actually talking about this intermittent high-intensity exercise, which is supposedly addressing one of the main barriers to exercise, and that is that it's time efficient. So you're actually doing...
And is it time efficient? There's certainly plenty of people marketing it.
It certainly is. There's some
So there's bursts of high intensity, low intensity. It's walking
walking,
Sprinting,
running,
sprint, yeah.
In some instances, in a lab or gym environment, excuse me, you can actually do literally 1 minute of hard exercise and rest for 1 minute, and then do that, and you can do that 10 times. And 2 weeks of that exercise is actually, at least in a diabetic population, improving glucose control. So we
This
don't
is where
know.
the shouting and screaming comes in, isn't it?
Yes, it is. But in terms of PCOS, that is areas that need to be researched, and that's certainly research that myself and Helena are planning to doing over the next few years.
Is there an increased risk? This is from Michael. I think it's South Australia or the Northern Territory. Is there any reason for increased risk of endometrial cancer in women with PCOS? Jackie?
Yes, well, there can be. It would appear that there is a slightly increased risk, and the reason that happens is usually in women who are having very few periods. So the endometrial lining builds up and it becomes thicker. So they're usually in women who are having, say, 1 or 2 periods a year. So that is a reason why we would sometimes use metformin to regulate cycles and ensure that women are having more regular cycles, or possibly to use the pill to protect the endometrium.
Well, thank you all very much indeed. I mean, one of the messages here, which we actually emphasised earlier, is that you've got to work with other people. Your model of care has got to be adapted to your local circumstances, but you need more help than just you as a GP, although there are lots of people watching who are not GPs who are also part of the primary healthcare team. And there is a resource page at the Gene Hills Foundation's website, and we can have links to that on the Rural Health Education Foundation website. So with lots of fact sheets there for you as well. What are your take-home messages, Nigel?
The first one is to be active for as long as possible, so try and take on sustainable activity, because exercise is as good as medicine with very few side effects. So if you can keep that up, you'll hopefully have a healthy, long life.
Apart from self-esteem loss when they've shouted and screamed at you.
Something like that.
I've been doing Biggest Loser for too long. Sorry, Helena.
You have. My key take-home message is that there is now good evidence-based advice. This is actually the first international guideline in PCOS, so I'd encourage people to use it. It's common. Please make sure we diagnose it early, and these women need a lot of support around prevention of weight gain. Prevention, prevention, prevention is the message in this condition.
Kate?
Yeah, so my message would be just that lifestyle, as we've talked about tonight, is really important. And as we've said, I mean, even small amounts of weight loss and just the actual changes to lifestyle themselves can actually make quite a big difference in terms of managing the symptoms and also the preventing long-term health problems.
Jackie?
Mine would be to try and work out, I know it's difficult sometimes in rural and remote communities, but try and work out how within your practice you can have a team approach to support these women.
Thank you all very much. Fascinating. So I hope you find it fascinating too, this programme on Polycystic Ovary Syndrome and the new guideline recommendations. This programme was funded by the Department of Health and Ageing with additional support from the Gene Hills Foundation for Women's Health. For more information, you can get it from the Rural Health Education Foundation website, rhef.com.au, or Gene Hills, but we'll have links for that on our website. And you go to the PCOS programme page and click on resources. And if you are a clinician and a health worker, don't forget to complete and send in your evaluation forms, which can be found on the web page. You'll receive a certificate of attendance and, if eligible, CPD points. I'm Norman Swan. I'll see you next time.